Well, it's 12:35. Let's get started. This is the Clinical
All right.
Consultation Network. We do this every Tuesday at 12:30, so welcome. We have Edna Ayer here with us today. She is the program director for Beyond Care Living, and so we're so happy to have her as our guest today. Before we get started with that, though, I have a little something I want to share. This is a little bit of a personal thing, but I just want to give a little bit of a shout out to my wife, who is retiring after over 30 years as a teacher in the Rutherford County school system. She just went to her retirement celebration a few days ago, and so she got this plaque, but that plaque really uh, does not capture what her career has been, because she's a great teacher. She really cares about kids. She knows how to interact with kids, and she's really smart, but she's got a lot of small town values, I think, that helped her along the way. And so I'm just hoping and praying that she can stay safe after this, because she certainly deserves it. And I just wanted to give that little shout out. I hope you had been recording already, Babs, because I want her to be able to see that I gave her this shout out later.
Well, you
But
broke up a little bit in the middle. You might have to
oh
redo part of it.
well, maybe that'll work out okay. But anyway, I'm sorry for the indulgence, but I just wanted to give her a little bit of a shout out as she approaches that retirement here in just a few more days. And
Sorry, that's awesome. We love to hear that. And thank you for sharing.
who said that? Did you say that, Babs? Oh, okay. Somebody came on and gave me a little bit of encouragement there. I appreciate it. So I'm going to move us on. Babs, if you'll bring up the intro slides. Oh, I have to stop sharing. All right. So, as I already mentioned, Edna Ayer is here today from Beyond Care Living to talk to us about a person that she's supporting and she wants to get a little bit of advice about. I think they've got a lot of great things going on with this person already, but she's just seeking to get more information if we can to try to help her. And today, as we discuss this, I really want to get everybody involved in this, because I don't want it to just be about
Susan.
that we'll refer back to periodically, and we'll ask for our audience to answer these questions to the degree that they can. So if you'll just be prepared for that as we get into it, that will be great. Next slide. So, upcoming on CCN next week, we've got our own Michelle Bagby, who is going to be here to talk to us about 10 Start. And what better thing to talk about in this day and age? It's a very important program that we offer, and so glad that she's going to be here next week to discuss that. Then on May 23rd, it's our fourth Tuesday feature, and that is going to be Dr. Brandy Kelly. And this is all part of our NAD collaboration. We do that every fourth Tuesday. So I hope you can join us on May 23rd for Dr. Brandy Kelly. On May 30th, we have Tam Ho and Volunteer Behavioral Health here to talk about 988. This is the suicide hotline. And they're going to be here to talk to us about that and all the things that implies and how it can be helpful within our systems. And then on June 6th, we're going to have people here to talk about Voice It. If you're not familiar with Voice It is for people who have articulation problems, difficulties getting their message across in a way that other people can understand. Voice It is a great system because it's technology that translates what the person is saying and gives it to you clearly so that you can respond to the person. I'm really anxious to have them on here on June 6th. So that's our upcoming lineup for CCN. I hope you'll join us for each and every one of those presentations. And now it's time for our Get Smarticle. And Edna sent me this article. It's a very interesting article, very detailed, very small part of what we do, but you are going to get smarter based on this article. I promise you that. Next slide. So the issue of concern here is that people with psychosis may or may not have the symptom of auditory hallucinations. So some people's profile will include hallucinations. Other people's profile may not include hallucinations. And that can be a very important factor in determining what the person's needs are. This study evaluates the extent to which people with psychosis have a history of childhood sexual abuse, depending on whether they do or do not have auditory hallucinations as part of their symptom profile. So this is going to be, I think, really interesting when you see the data behind this. Next slide. So the method here is they administered this childhood trauma questionnaire to people with and without a psychotic disorder. And there are 5 dimensions on this childhood trauma questionnaire related to sexual abuse, physical abuse, emotional neglect, and physical neglect. The participants were 41 people with a psychotic disorder who did say sometime during their life they experienced auditory hallucinations. 37 people were people with a psychotic disorder who do not endorse lifetime EH. So they're saying they never had any auditory hallucinations. And then there were 37 healthy controls. You see the breakdown of female, so you can do the math and determine how many males were in the study. So it's about half and half. Groups were comparable. If you look at the demographic characteristics, the groups were very comparable. Next slide. So the results of this study, this is quite interesting. So when you look at the left, the graph on your left, this illustrates just the differences between those groups that I just described without considering any other factors. So you can see that those who experienced high, and by the way, I'm focusing on sexual abuse for this presentation. There were 4 other, as I mentioned, 4 other dimensions measured by the childhood trauma questionnaire, but I'm looking specifically at sexual abuse here, and the study really focused a lot on sexual abuse. And so you see there was a much greater tendency for the group with auditory hallucinations, or they had a much higher score on the sexual abuse questionnaire than did the other 2 groups. It was interesting when you put gender into that, though, because females are at much greater risk for this than men. And so when you're evaluating a female, what I'm going to get into the implications of this in a minute, but you can see that females who experienced auditory hallucinations at some point were much more likely to have a higher trauma questionnaire score than the other 2 groups. And so, particularly when you're looking at females, this tendency to have auditory hallucinations is much greater than it is for people who have not experienced hallucinations. Child sexual abuse is much greater than those who have not experienced hallucinations or those who are healthy controls. Next slide. So, ancillary note, just this is something else I want to say because there were those 4 other scales on the CTQ that were important. Both groups with psychosis scored significantly higher on all forms of childhood trauma than did the control group. I think that's something we don't often think about with people with psychosis, is that it's not just necessarily a physiological problem that they're experiencing, but they also have a history that may contribute some to the symptoms that you see. The most significant difference between psychotic and control groups was in the area of emotional neglect. So I thought that was interesting as well. But these are ancillary notes. I'm really focusing on the sexual abuse, but those other forms of abuse may also be quite important in this question. Next slide. So what this means is that women with psychosis who report childhood sexual abuse were significantly more likely to report auditory hallucinations. And so if you're working with people out there, you may think, oh, well, I want to try to narrow it down to just the one thing. I'm trying to get it to simplify this thing and get a diagnosis. But if you focus too heavily just on psychosis and not on the person's abuse history and their trauma history, then you may be missing a whole big portion of the picture that you really need to be attending to. This study demonstrates that it may be useful to identify subtypes of psychosis as with or without auditory hallucinations, because that may give you clues as to what the person's history is. And of course, you should go deeper and find out what that person's history of sexual abuse may have been. The presence of auditory hallucinations may warrant further investigation of the abuse history, as I'm just talking about. So that's our Get Smarticle for today. I tell you, I got a lot smarter reading that article. And it was a very good article. I think it really highlighted something that's quite important in clinical work, and I really congratulate you on finding and submitting that article. It's really great.
Thank you, Dr. Davis.
And I'm so happy to have you here today. I appreciate your coming and sharing this case with us and discussing all of this. But before we get into all that, can you just tell us a little bit about yourself?
Yeah, my name is Edna. My name is Edna Iyere. I'm the program director
I've been
of Beyond.
mispronouncing your name already, so it's Iyere.
No, it's Iyere. Iyere. Yeah, I'm the program director of Beyond Care Living. I've worked in the field of mental health for more than 20 years now. I love what I do. I take pride in what I do. I love the people that I support. I love the people that support me too from the regional office. I've always had this big team support from them. If I'm in a jam, I reach out to them and they will always put me through, and I thank them for that. I just love what I do, and that's who I am.
That was evident through the preparation that you've made for this presentation, because you put together a whole Microsoft Word document with all the little pieces of this. And, it was very evident that you're really trying to understand Jolene, who we're going to be discussing today. And so I'm really glad to have you on here to discuss this. Now, before we jump into that, let's do this. I want to check on your interesting fact about yourself.
Okay.
So tell us your fun fact about Edna Iyere.
My fun fact is I like to hang out when I'm free, and I like to go to a place where I can relax and have fun.
Okay. Is there a particular place you like to go, or are you not wanting to mention that? Because I don't want to get you to say anything you don't want to say.
And I like eating too. Any place there is good food.
Okay, all right.
So if I'm going out, it comes with food.
Now,
So if I'm going to I like going to restaurants. So I go with, that's the fun fact about me. I like to hang out where I can get good food.
do you have a particular restaurant you like to go to?
Unfortunately, the restaurant that I really liked was bombed down during that when downtown was
It was
So
bomb.
I have a
Spaghetti
restaurant that I
Factory?
used to, yeah.
Oh, okay.
So I've
Guessed
not
it.
been, I've not been to one. I'm thinking to go to one in Chattanooga pretty soon when I have the time.
Well, I hope you'll get the opportunity to do that very soon. You mentioned another interesting fact, though, in your presentation about being an attorney.
Yes, I'm a lawyer. I was a lawyer in Nigeria before I came here. I still provide free services for people, just advising them. So you can always ask a question, and I'll be there to answer anything that you have when it comes to legal terms. So I advise people, and it's free of charge.
Okay, so I've got this problem with my real estate taxes. Can you help
Okay.
me with that? No, I'm just kidding. I don't have a problem. I'm just kidding. I just thought that would be funny. So, all right. Well, why don't we start? And I want to remind everybody we've got some questions up here in the chat, and I'm just going to quickly review these questions so that you can be pondering them out there in the audience. First, how to decrease Jolene's inpatient hospitalizations. So I think we're going to learn that she has a lot of inpatient hospitalizations, and so we're working at trying to figure out ways to decrease that. Secondly, could a B52 injection be incorporated into her current psychiatric care to decrease hospitalizations? Is she really hallucinating, or can she control experiencing hallucinations? And what is it about the psychiatric hospital program that attracts her to return? Finally, how can we best support Jolene when she is feeling overwhelmed and that she is responsible for all her family issues? So I think this is going to lead to a really great discussion. Again, I want to crowdsource this. I don't want to just be doing all the talking here and Edna doing all the talking, but I want you guys to get involved and to try to help us answer these questions as we go through. So, Edna, with that, I'm going to let you launch in and do a presentation regarding this, and then I may interrupt you rudely to ask questions or to get our audience engaged.
Okay, thank you. So Jolene is a 34-year-old competent adult who resides in a supported living, receiving support from Beyond Care Living. She's highly articulate and communicates all her needs, wants, and desire verbally. Her vision of a preferred life is to be mentally stable, healthy, and improve her nutrition and diet management. Jolene also wants to decrease hospitalization and self-injurious behavior. Her friends describe her as a hard worker, open and honest, a self-advocate, independent, smart, funny, and likes to help others. She is very creative. What is important to Jolene, it's her privacy, being accepted by others and treated as an adult, having control over her life, being asked to do something only one time, for people to listen to her, to have consistent staff. She prefers older staff that is submissive to her, having consistent sleep, having pillows and item of choice in the bed with her when she goes to sleep, having spending money, being praised for good work, learning how to pay her bills independently, staying engaged in early activities, staying in contact with her friend Amber, her niece and nephew, attending church as she chooses, having natural support, Pam, in quote, mom, and Christine. Jolie does not like loud noises or talking. A normal routine for weekdays and weekdays: wake up at 7 a.m. to play on her phone and sometimes shower, to check her BS by delegated staff and then eat breakfast between 7:30 and 8 a.m. Get dressed and leave by 9 a.m. to go out in the community or something she wants until 2 p.m. when she comes out. Return home to eat dinner by 6 p.m., goes to bed at 10 p.m. Jolene currently received level 6-2 support due to the level of supervision needed to support Jolene. Risks include verbal, physical aggression, SIB, suicidal ideation, swallowing objects, and elopement. Jolene had many hospitalizations due to hearing voices instructing her to harm herself and attempting to harm others or herself. Jolene often becomes upset and she communicates with her family. If she appears upset, staff remind her she can end the conversation or she can hand the phone to staff to help end the conversation. This is a trigger for Jolene. Currently has no BA, but Jolene does attend therapy with Life Connect. BA is being swatched through her insurance, which currently an assessment is going on. Jolene has a cross-system crisis plan and a project transition plan. Our safety plan has been updated. Jolene's current diagnosis includes psychosis, hallucination, anxiety, panic anxiety disorder, major depression, EPS, bipolar mood, PTSD, glaucoma, hyperlipidemia, asthma, GORD, hypertension, diabetic, sleep apnea, irregular measles, magnesium deficiency, vitamin D deficiency, constipation, hypothyroidism, allergic rhinitis, migraine, dry scalp, obesity, insomnia, bedwetting, B12 deficiency, ear infection, upper respiratory infection, granuloma annulare, tremor, ocular, hypertension, dystonia, Hashimoto, and thyroiditis and edema. Jolene is allergic.
I just want to stop and congratulate you for pronouncing all of those different diagnoses. That is a laundry list of
If I
diagnoses.
pronounce them right.
Well, I thought you did a good job.
Thank you. Jolene is allergic to doxycycline, penicillin, Idol, Percocet, Mood, Latest Glow, Bleach. Carries an EpiPen.
Let me ask a quick question of you there, though, because now the B-52 shot, that's a nickname for that. And it
Yeah,
usually
that's correct.
the
That
administration of Haldol, does it not?
Yeah.
Okay.
You would think they will see that and you would think they will do something about that. But I was made if you go through my report where she told me somebody had put that as an allergy for her, so they will not be giving her, but that didn't work.
Okay, so she's not really allergic to it. She does not have an
she's
allergy.
not allergic to it, but that is what her mother was physically abused during pregnancy and also had an accidental electrical shock. No complication of delivery, and she met a developmental milestone. Allegation of sexual abuse by her father around age 6 to 9. DCS was involved and she was removed from the home, but later returned with a safety plan. In 2003, reports she began running away, lying to her parents and refusing to go to school. Placed in custody for being dependent and neglect child rather than a delinquent child. Jolene has history of several reportable events that led to incarceration or psychiatric hospitalization. She tends to swallow non-edible matters item and to put things in her mouth, resulting in emergency room visit / hospitalization. She will not swallow plastic item. She tends to prank call people and tell untruth stories about staff or situation. Jolene has a history of displaying severe and unpredictable behavior, which include elopement, threat of elopement, attacking others, SIB, and threat to kill others, then may have moved to her home. Jolene will overeat or refuse to eat to affect her blood sugar, to inflict self-harm and go to the emergency room.
So Edna, you made specific mention of the fact she does not swallow plastic items. Can you explain that a little bit further? Is there any meaning behind that?
She doesn't swallow plastic item because Jolie knows if she swallow plastic item and she goes through the x-ray, she's not going to be admitted. The x-ray doesn't pick it up. So what she wants to do is look for anything that has any metal component. That is what she wants to swallow.
I got you. Thank you for that.
You're welcome. HROC restriction include all sharp will be always locked. She used a pen with staff supervision and locked when finished. Room swept beginning of each shift and throughout the day to ensure nothing is hidden that could harm Jolene. Phone calls are monitored via speaker's phone or at Jolene's request. Things that Jolene has shared with me are issue with needing hospitalization starting when she was 13 years old. When she goes to the hospital, she receives a shot that makes her feel that the world does not exist. She goes into a very deep sleep. With time, she learns she cannot do without it. She states she will do anything and everything to return to the psychiatric hospital to receive the shot B52. Combination of which is Ador, Ativan, and Benadryl. She does not receive this shot during ERO visit. She states she will do everything to be admitted, so she receives the shot. She has also shared that she used to elope to go buy drugs when she was young. Her behavior episodes tend to occur in the evening between 8 p.m. and 9 p.m. Jolene will tell you untruth. She will state her medication aren't working well upon discharge. Everything is fine, not hearing voices, only to report to her doctor that the medication is not working within a few hours or a day later. When having a behavior crisis, staff will notice Jolene has packed her clothing. She will start by stating she is not feeling well. Staff will take her vitals and they are normal. Staff will let her know her vitals are normal, attempt redirect, remind her of her coping skill, such as calling a counselor for project transition or Life Connect, guidance center, ISC, Beyond Care Management Team, use a weighted blanket, coloring, bunch of other stuff. She will then scream. She does not.
And let me ask a clarifying question just to make sure I understand. Are you saying as one of these episodes begins, she starts by packing her clothes up? Like she's just planning on,
yes,
this is going to result in me going to the hospital. So I'm going to pack my clothes up and then we'll get into all the other stuff that gets me into the hospital.
Exactly. She will pack them before the episode will start.
I just wanted to make sure I understood that correctly.
Yeah, the packing will be done first. As soon as she finishes packing, that's when she will start the episode of everything not working.
Got it.
She will then call 911 on speaker, threatening them, if you don't get here, I'm going to kill myself. State nothing is working, my head is full and nothing is working. Then she's screaming, she wants to kill herself, but not making any attempt to do so. And you are trying to redirect her. She watches the staff until the police arrive. She will then destroy property while they are there. All this while she might be calm without doing anything. She bang her head in front of the officer, so they take her to the hospital. Her goal is to go to the hospital. If she's really in distress, she will not want to take her bag. But if they intervene and state she must go, and that is not distress, she will state, wait, I must go get my bag. When she was released from jail, she had the best behavior. because she did not know the outcome of pending court hearing and she didn't want to return to jail. She stated she was pepper sprayed in jail for 2 months. She had no auditory hallucination, no behavior issue. Then after court date, the ruling was she's not competent to stand trial. The behavior and hallucination returned. I asked her, you are allergic to Adol, but when you go to the hospital, they administer B52. She stated the doctor put me, which was what I said before, but I'm going to go ahead and read it, put it in her record so she would not be prescribed Adol. She's addicted to the injection and she will request the injection. I really need that shot. I need somebody to give me that shot, unquote. Being broke is a trigger for Joey going to the hospital. When she returned from the hospital, she knows she will have money to spend. She has not had access to money in the hospital for a long time. Okay.
Wow. Okay. Okay. Now, here's a question. Is she really psychotic?
No, she's not. She is the most pleasant person and very manipulative. She's not psychotic. On a daily basis, she's not. It's
Well,
not. But the question is, when the article you have that I sent to you that you just posted, this is somebody, Jolene is somebody that has gone through a lot of trauma.
yes.
Even when the trauma happened, she had an opportunity to be in DCS. That she's still searching. She's still looking for that emotional connection from the family. It's not there.
Yeah. Yeah.
It looks as if she's the big child. She's the big person. She has to reach out. I have never seen anybody reach out to me when she's not around. And it's hard for Jolene because it's only when she comes, it's okay.
Yeah.
So there is this past trauma that is really coming to play, even when she has the best support system.
Yeah.
And then Jolene, this is not her saying it, this is her saying this in a full circle, saying this thing happened when I was 13 and I've been going for it for the past how many years? She's 30 something now. And she's been taking B52.
Yeah. And let me ask this too. Do you know much about the child sexual abuse that she experienced, or the child abuse that she experienced? I'm not sure if you stated it was sexual abuse or not.
Yeah.
It was.
She talks about it a lot. It's from the dad.
Okay.
It's from the dad, and she was 6. When it happened for years.
Mm-hmm.
And she will always say, I feel bad because I feel cheated. When they took every one of us, including my sibling, they only took me and the others were there. So there is this disconnect from the family that she's seeking for. She's looking for it, but it's not there.
Yeah, going back to that study, I wish they had added a group that was people who experienced child sexual abuse but did not have a psychosis. Because one of the things that happens is a lot of times those two things get confused, because you may see something that looks like auditory hallucinations that's more like a flashback to child trauma, than it is a result of a chemical imbalance that causes you to have auditory hallucinations. And so there can be a great deal of confusion between those two circumstances. She has the PTSD diagnosis in her record,
That's
which is
correct.
I think good, but it may be, and so an extension of PTSD beyond what is typical, like everybody who has PTSD has a reaction to is triggered by different sorts of things. But when this becomes a pattern and it affects a person's self-image and the way they interact with others and, everything about their lives, it turns into something we call borderline personality disorder. And, there are an awful lot of people with borderline personality disorder who have this tendency to want to go to the hospital a lot. And I do think I just would question this. I would ask, and we got a couple of good questions from Christina, who is the ISC, saying, wonder if the abuse happened at night. I think that is a very apt question about this. But what do you think that, okay, so let's erase, because I'm just going to accept as the premise that you're saying that she wants this B-52 shot, but why does she want that shot? What does that do for her? How does that help her?
It comes out, she is in a state of like, forget everything, nothing is in existence anymore.
Yeah.
So
You said she goes to sleep a lot of times after she gets that. And so she's able to get some restful sleep. She's divorced from reality at that point. I don't
there
have
you
to
go,
deal with.
reality.
Yeah. And I'll tell you, a lot of the people I've worked with that they feel like just being in a community setting is unsafe, and it's anxiety provoking for them. And so I think you have to, at some level, kind of get the specifics out of it and think about generally, what is it she's trying to accomplish at this point? It seems to me that maybe one hypothesis would be that she's trying to just be safe and to not have to experience the overwhelming anxiety that she may be experiencing at those times. I don't know. What do you think about that? How do you react to that?
I think that is true. I think because she's talked about it a lot. So I think Jolene is going through that overwhelming anxiety. And she thinks that place, getting that shot is safe.
The other thing I was going to mention is that you talked about how during the time after her incarceration, she was able to hold everything together pretty good for a period. It seemed like the consequences of potentially going back to jail were outweighing the need, because that would be a worse outcome for her than having to stay at home essentially and doing well. Now, actually, that's not an uncommon response, but I think it does go back to this idea. Well, maybe she is capable of holding this together. It's not so uncontrollable like you would expect in a psychotic disorder, where you can't control these things and it's just happening to you. But I would quibble with one word you used there, where you said she's manipulative, because here's the thing I want to say about that. We don't get very far with that because there's not much you can do about it. She's going to figure out ways to do these things. What we have to really back up and do is address the basic cause of it. That's the only way that we can get her to think about other things, is to say, okay, how can we help you feel safe where you are? What can we do to increase your feeling of safety in this moment? How can we validate the things that you're thinking right now as we go through this? And this is so tricky because you're trying to probably keep her from going to the hospital, but at the same time, you don't want to invalidate her judgment. She's telling you, and she's got precursors out there. I mean, she's telling you way in advance, hey, I'm packing my clothes up here because I need to go somewhere. But nobody reacts to her packing up her clothes. We only react when it gets to the point that something bad has happened. And that's another little tricky piece of this that I think has an impact on how she responds. Now, I'd like for the group to react to this first question before I try to react too much to it. And so here we got Christina's giving a lot of input. And Christina, maybe you want to come on and just talk about that for just a minute. But while you're doing that, I want to ask the audience the question, what can we do in this circumstance to reduce hospitalizations for Jolene? So everybody who has a response to that, please just enter it in the chat box. Don't worry about whether it's the perfect solution or not. We just want to hear from you on it. And we'll go back and go through some of those in just a moment. But Christina, you want to come off and just explain a little bit about some of the things you've been saying in chat?
Oh, good afternoon, everyone. How are you?
Thank you, Kristen.
Very well. Thank you for joining us.
I can elaborate on some of the things. Now, Life Connect has been working with Jolene for quite some time now. And she goes to group and she goes to individual therapies and tells everyone in the group everything's fine, it's great. They work on coping skills, during group and stuff like that. So what she is doing is breaking down the team's communication between each other. She tells Life Connect everything is good. She feels great. She does everything that they want to do because she's positively reinforced. You know what I mean? She's getting that attention that she likes. Then she'll tell me something completely different that she's been struggling for days and days with hearing voices and stuff like that. And you have to dig a little bit to try and find out what the trigger is to it. And you don't know whether she's telling you the truth or not because she's trying to manipulate each of the team to get exactly what she wants, more attention and medication, in my opinion. Okay. I think she's struggling at night because a lot of times when she calls me in crisis mode, it is in the evening. She wanted sleep medication. We went through a conversation about melatonin. We went through all these other medications, and she said the only thing that really worked for her was trazodone. Well, they got her trazodone, and that only worked for like a week. And then she couldn't sleep anymore, and she went back into crisis mode. If she says if she can sleep at night, then she would feel better, she'd feel safer, but she can't sleep at night. That's one of her complaints as well, is she will tell lies about staff, and especially on third shift, false allegations of staff sleeping on duty. So I think the nighttime is possibly when the abuse started, and how we are getting her to deal with that and to get everybody on the same page. I set up a main email thread. So every time, even the staff in the house. So every time she displays these triggers or what we're noticing as triggers, we're shooting out emails to each other so everybody's on the same page so she can't separate the entities and try and manipulate them.
So just to level all of this, how many times has she been hospitalized for
Here, I'll show everybody. This is just through Blue Cross Blue Shield. I don't have Medicare.
Okay, let me give you a standard.
That's her.
just a general, you don't have to give me exact numbers.
Since
Just
she's been with us, she's going to 2 years. I've only provided services for her for 4 months.
Yeah.
Okay.
So
So she spent most of her time in the hospital.
Yes.
Oh, okay. Well, there's no place, there's
Absolutely.
hardly any place to go but up from there or to get better from that point. But I guess you could be less than 4 months. So we'll call that a win. But okay, thank you for putting that in here.
Yeah.
I know it's a lot of information, but this is just on the Blue Cross Blue Shield side. I don't even have access to the Medicare billing side. So there may be even more than these from 2019 to today. And currently she is at Crestwind.
Yeah, and this, I tell you, well, before I do that, let's go to the chat box and let's hear a little bit of what people have had to say about this. Babs?
So some of the comments were that the B-52 could be a coping mechanism because she can't handle her emotions at night. Another one said she may want the shots and the frequent hospitalization as a way of communicating needs for attention as in somebody talking to her about her emotions. Another person said she needs ways and means to convey what she's feeling. Sarah Andrews said, am I remembering correctly that there was a mention of drug use? More discussion about not necessarily manipulation, but could be seeking something that works for her.
Yeah.
Yeah, a lot of people are commenting that there seems to be a communication issue that's being ignored.
Okay, so that's some good stuff. Now, so we had a person who is very similar to this, and I think one of your questions was, Edna, about whether we could arrange for her to get a shot without having to go to the hospital, which is something that we did in this other person's case, and it was almost exactly the same pattern where it would be at night that these things would emerge for her. And this person had a tendency to insert objects in her skin. She would take a metal object and would insert it under her skin. And that was just her pattern of self-harm that often led to these hospitalizations or ER visits and other concerns like that. And what we had done for a period of time, her psychiatrist finally got to the point that he was kind of frustrated with the back and forth to the hospital. So he did. He arranged for her to be able to get the cocktail that she wanted at the mental health center, at the emergency area of the mental health center. She was able to go there each evening and get a shot. And now the liability though of that over the course of weeks became heavy on the psychiatrist, and he eventually said, no, I'm not going to do this anymore. This is unethical. This is not appropriate. So they stopped doing that, and she did benefit from getting that for that period of time. She was able to sustain herself better. She felt more satisfied, but in the psychiatrist's opinion, the risks of that outweighed the benefits. I'm not necessarily saying that applies here, although Haldol is a very heavy drug. I mean, and it is a drug that when you take it a lot, it can cause something called tardive dyskinesia, or at least extrapyramidal symptoms, which are something to be guarded against. So there would be a risk in doing that, but we have to balance that against, well, if she gets to the hospital, how frequently is she going to get it? Is she getting it every day? Probably, while she's in the hospital. So I think there are a lot of things to consider in the benefit risk analysis there about whether that might be an approach to this and something you might discuss with the psychiatrist. Beyond that, there were a couple of comments here made about people didn't use specifically the word validation. But one thing I think you have to accept on the front end, 2 years is a very small period of time in the life of a person who has this type of abuse in their history, and who has this type of reaction to that abuse in their history. Rome wasn't built in a day, and you are doing so many things, I think, currently that are very supportive of her in this circumstance. The one thing I'm going to caution against, I'm going to reframe this word manipulation, and the reason is not because it's inaccurate, because it probably is somewhat accurate in how you would describe this. But the problem is it leads you into a path of solving the problem that's not helpful. because we start to blame her for it, and it's really not her fault. And I don't want to be making excuses for her, but it's not her fault. This happened to her, and she is having this reaction, which is largely outside of her control. I know we had the 2 months after her incarceration, but she had just a stronger motivation at that time to avoid it. But in normal times, it's more difficult for her to manage this. And I would suggest that you've got to really move into this area of validation. And what I would be doing, because by this point, and what our system does really is put all the, you remember when Dithu Rajaraman was on here a few weeks ago talking about trauma-informed ABA, applied behavior analysis? He said that we put the smaller things on extinction. So in other words, we don't provide any reinforcement for the smaller things. We only provide it when the person gets to a really bad level. And even though I understand this might be perceived as, oh, well, we're going to have her in the hospital for the other 4 months of the 2 years if we do this, but maybe the process is when she starts to pack her bags, try to help her. Validate her judgment in that circumstance. She's feeling like she needs to get away from this. Let's help her figure out a way to get away from it. Now, maybe the buyout in that is finding an alternative way to do that, an alternative way to get away from everything. And that may take some time for her to learn, but that might be the path that you want to take. And of course, you got an assessment going on by your BA. I think that's a good process, and maybe some of these factors can be explored in that, and that these can become potentially part of the behavior support plan. The one thing, and I've done this before because I've had people who wanted to go to the hospital, and I treated it pretty much from a straight behavior analytic perspective. Okay, the hospital's the reinforcer, so let's do this. Let's not hospitalize the person when this happens. Well, the problem there is that it escalates and it gets worse and worse and worse until you finally have to give in and do that. And that's, you're actually making the problem worse rather than better under that circumstance. So you can't just set a moratorium on hospitalizations. You're going to have to dial it back more gradually and a little more craftily, I think, than that. Let's see, what other questions do we have that we wanted to ask people, Babs?
Well, we
Yeah,
just
I have
got,
one thing to say, Dr. Davis. She will always say, I want to go to a long-term facility where I can be safe. When it
Yeah.
starts, she will say, I want to go to a long term. And when she's in the hospital, that is what she will tell them. I need to go to a long-term facility. I need to go there. That way, I won't have the opportunity to want to kill myself or injure myself.
And it very likely, if she were to be able to attain that would probably, she would probably do a lot better in that circumstance. The question is, what is she missing with that? And, we have a system that is built on community services. It's being stretched to the max with somebody who's been in the hospital, been out of the hospital for 4 months in the last 2 years. I mean, that's, a very small amount of time that she's been out. But the goal is to teach her to be able to tolerate community settings and to be able to be part of her community. But that's a benefit risk analysis too in all of this. And then also the availability of that type of facility that she's looking for is not great. And most of the time, people are expecting that someone's going to be discharged at some point and have to be able to cope with that. And actually, one goes into if a person goes, no, actually, it wasn't that article. It was a different article I was looking at, which stated that when people go into the hospital, their symptoms improve. People with borderline personality disorder. The question is not that, but what is it when they go back to their community setting or to their home? Are those changes that they see in the hospital sustainable? And oftentimes I find that they're immediately unsustainable. And so we're not making progress on helping the person adapt to the community setting. We've run out of time. I probably took too much time, but I do appreciate the comments that people made in response to that first question. Edna, Christina, I appreciate both of you for coming and talking to us about this case today. Please don't take anything that I said, take it all with a grain of salt, because I'm just learning about her now, and you guys have known her for some time, and it's obvious that you're approaching very many things that are very helpful to her and trying to support her. So I want to validate you in that regard and just say congratulations on doing a very good job with a very difficult situation.
Thank you very much.
And I want to thank our audience for their input today. And we will return to this subject again, I'm quite sure, because it's an oft experienced thing that people have out there. So thank you so much. This is the Clinical Consultation Network. We do it every Tuesday at 12:30. Join us again next week. We'll have another exciting episode. See you, everybody.
Bye.